Thanks for being here, everyone. My name is Bashar Stati. I'm at Emory University in Atlanta, and it's my pleasure to welcome you to our 2025 Pine HIV session to mark World AIDS Day. Um, just a little bit of background on the conference first. So we started doing these a few years back. This is actually our fifth HIV session. And the original idea here, for those who know her, was Kira Cohen's. She used to run a session on NTM where they got together a bunch of different infection experts from across the country to all talk about NTMs. And we brought it into our ATS assembly a few years back to mark different infections. And it's been a fun way to increase contact and kind of a sense of community around folks who all focus on the same infectious processes around the world. This will be a case-based presentation, and so we'll have an interesting case with some panel discussion to kind of guide us through it. And I'll introduce everybody to do that in just one moment. Before that, though, if you do have any questions that pop into your minds or any comments you'd like to make, please put them in the Q&A section down on the bottom bar there. I've never used that before. I feel fancy. We'll all learn about it together, but we will, make sure we have some time to get to all of those questions. Just a few notes on World AIDS Day before I introduce everybody. So this has been going on in the United States actually, I shouldn't say the United States, across the world since December 1st, 1988. And so this was just to draw attention to the HIV epidemic. And it's really been about coordinating global efforts to combat HIV. Unfortunately, this is not the greatest climate for global coordination at the moment, but that shouldn't stop us from all getting together and trying to coordinate our efforts. Every year when we do this, I review the WHO statistics for the HIV epidemic, and every year I find that another about 1.2, 1.3 million, depending on the year, people have been diagnosed with HIV. And we still have around 41 million people across the globe living with HIV. Since the start of the pandemic, or the start of the epidemic, 44 million people have died from AIDS-related illnesses. So we still have much to discuss. Obviously, there's been a lot of improvements over the last few years, and now we've got pre-exposure prophylaxis, which has made the situation better in many parts of the world. But we still have a lot of work to do on viral eradication, chronic illnesses, et cetera. And that's kind of where this conference came out of. So with that, let me introduce our panel here. So our first discussant I'd like to introduce is Josalyn Cho, who is an associate professor of internal medicine in pulmonary critical care and occupational medicine, as well as the vice chair for professional development in the Department of Internal Medicine at the University of Iowa, where she also serves as the director of the Iowa Inflammation Program and the co-director for the Center for Immunology and Immune-Based Diseases. Our second discussant will be joining us as soon as she gets out of her car. I think she's just rushing back from an appointment, and that is Neelima Navuluri, who is an assistant professor of medicine and an assistant research professor of global health at Duke University, where she is also a member of the Duke Cancer Institute. And our presenter today comes to us, as you can see on the slide here, from Weill Cornell Medicine, where he is an instructor of medicine in the Division of Pulmonary and Critical Care and works at New York Presbyterian Hospital. And that is Dr. Jonah Kreniske, whose name I just pronounced correctly. How'd I do? Is
You
that
did
good?
it.
All
You
right,
did it.
excellent. Well, with that, Jonah, I'll let you take it away.
Oh, thank you so much, Bashar. And thanks all for being here and for the opportunity to present this case in honor of World AIDS Day. This is the story of a patient who our group cared for the better part of a decade, and so it's really an honor to be able to share this story in his honor. So we first meet the patient as a 33-year-old man in 2011. He's a current smoker. He has a history of detectable hepatitis B DNA, and he has a history of HIV on heart with an undetectable viral load, but an unreconstituted immune system. His CD4 count is currently 175. It was 200 when he was diagnosed in 2005, and he actually spent 2 years with no ART between 2005 and 2007. Um, he's coming in to see you at the Cornell Pulmonary Clinic because he's been told he has pulmonary sarcoid. He first presented to clinic in 2011, and he'd been diagnosed with sarcoid 1 year prior, and he'd been treated with corticosteroids since the time he was diagnosed. He says that he was first diagnosed on CT imaging and biopsy out of state during a pretty severe presentation with respiratory illness. And as far as he knows, he doesn't have any extrapulmonary manifestations, and he's never had an echocardiogram. But he has a really limited exercise tolerance for a man his age. He can only walk about 4 blocks, and he can't run more than an eighth of a mile. You get PFTs and see that he has a moderately restrictive abnormality and a moderately reduced diffusing capacity. And his initial imaging shows diffuse ground glass opacities. He has a pulmonary artery diameter slightly above the upper limit of normal, and of course, significant mediastinal lymphadenopathy.
Excellent. Thanks, Jonah. So let's just start with some initial thoughts. Neelima, I'm not sure you're available yet, so why don't I start by asking Josalyn. So when we're talking about sarcoidosis and HIV, so I've been told from my colleagues who were practicing at the beginning of the epidemic that this was just something they never saw, and now it's something that we are seeing with increasing frequency. Is this something you've dealt with much, and do you see any sort of differences in clinical course or sort of management strategies?
Yeah, so I have not dealt with very many patients with this particular combination of medical problems, although it is pretty well reported in the literature. I mean, several case series and even retrospective analyses. Um, I'm curious if I could just ask a couple of questions. When about the, just to clarify for the patient's course, when was the patient's HIV diagnosed?
Yeah, so he was diagnosed in 2005, which would be 6 years prior to the appointment when you meet him for the first
And
time.
5 years before his diagnosis.
Yeah, so he was diagnosed with HIV 5 years prior to his diagnosis of sarcoid.
And how long had he been on treatment when he presented with sarcoid?
So he'd been in treatment for HIV for 3 years when he was diagnosed with sarcoid, and he was never diagnosed with any lung condition prior to pulmonary sarcoid. He had no history of childhood asthma and no history of COPD.
And did he, so if I was, I'm just sort of thinking like if I were seeing this patient for the first time, were his outside biopsies or infectious testing available to you at that visit?
They were not available, and they were very difficult to get. He was actually diagnosed uh, far off in a very different region of the country.
So and then my sort of second set of questions then is the usual kind of sarcoid history. So any any occupational exposures that would be of concern or medications or other things that you went through at the first visit in terms of increasing your confidence that this is sarcoid?
Yeah, so he had worked in factories in the past, but no sort of noxious fumes were identified in his exposure history. His only medications when he first presented to clinic were his antiretroviral therapy, and he had no history of unexplained rashes, no history of scleral icterus or other signs of jaundice, and no concerns about his vision.
Okay. So because the thing that sort of jumps out at me from what you presented, as compared to what I think has been most commonly reported in patients with HIV who get sarcoid, is that his CD4 T cell count is still low, and I would say below the typical range that again has been reported in most case series and most retrospective analyses. And so to me, that's just the thing that's a little bit curious. Patients with sarcoid can have peripheral depletion of their CD4 T cell counts. But both processes, so sarcoid typically is thought of as a disorder of activated CD4 T cells. And so I think what Bashar was sort of getting at, this idea kind of at the beginning of the AIDS epidemic, that the diseases couldn't coexist together, came from the idea that with CD4 depletion in the context of HIV, it'd be difficult to get also a CD4 driven disease. And And since then, most of what I'm familiar with, having been reported, patients have a reconstituted CD4 T cell compartment. So that was one of the aspects that struck me as a little bit unusual.
Excellent. Thanks, Jocelyn. Neelima, I see you're on camera, so I'm going to feel free to pick on you a little bit as well, if you don't mind. Um, so, you know, I think in terms of the diagnostic part, I think Jocelyn makes a good point. The first question here is always, is this actually sarcoidosis? We've all taken care of those patients where it was something else entirely and the right stains hadn't been done and the right diagnostic workup hadn't been done. It seems like that's going to be a little bit of a black box in this case because the data is far off ago that we're not going to be able to access it necessarily. But assuming we had, granulomas and they did all the right stains and didn't find any of the sort of competing differential items, in are these folks that you have sort of a treatment preference for? Do you treat them like you would treat sarcoidosis outside of HIV?
Yeah, I mean, I think it's a great question. And I think the point that Jocelyn brings up about sort of the CD4 count not being fully reconstituted is a little bit of a atypical scenario. And I mean, atypical in the sense that like this is an atypical scenario to begin with. And, the number of patients with HIV with sarcoid that I've personally taken care of, I can probably count on one hand. And so, I think we're living in a data-free zone in terms of like what the best and appropriate management is for. I think the approach is very similar, or at least I would, I think, and I was sort of joking earlier that sarcoid is difficult to manage in any patient, regardless of whether or not you have concomitant HIV. So I guess the things I sort of think about is where's their CD4 count and where do I think they are sort of in the spectrum of their overall immune suppression before starting additional immune suppression. And so the CD4 count of 175 gives me a little bit of a pause, but I think sort of steroids being first line to sort of see response and symptom improvement. And then thinking about additional therapies, and I think people probably have preferences and personal experiences with, whether they start methotrexate first or Imurin first or, Cellcept in some cases, if someone is steroid responsive. But I think, presuming that we feel very confident that there's not an infectious etiology that could be driving some of this and that we have a clear diagnosis, I think would be reasonable to sort of initiate steroid therapy, do a trial of steroids, see how he does with that. And then I think, hopefully quickly move towards a steroid sparing agent, given that he's young and can have lots of complications from the steroids.
I would just add, I think the one additional, not that he needs more, but one additional complicating factor here is the hepatitis B DNA positivity, which would give me even further pause when thinking about an additional immunosuppressive and the selection of that immunosuppressive agent. So, Jonah, you said no history of abnormal liver function testing.
So he had no history of known liver disease, other than the hepatitis B with detectable DNA viral loads. But on his liver function testing, he did have a mild transaminitis.
Yeah, I agree. I don't know that anybody's going to be super excited about pulling the trigger on an immunosuppressive under those circumstances, for sure. I also think at the time this was happening initially, I don't know that that was as common. I think most folks at that time period were still getting steroids, and you know how it is. You show up to the emergency room with sarcoidosis, you're getting more steroids. Kind of whatever was going on at the time was still, I think, much more common practice back 15 years ago or so.
Oh, that's a great point.
I guess the other thing I would add is if so if the decision is made to start prednisone, what's great is that you have complete pulmonary function testing and CT imaging to see whether or not, and you have obviously a symptom history to see whether or not he actually has a response to that to that therapy. Although he's so limited and he already has pretty good impairment in his pulmonary function testing, and it's not like you have a million other choices for how to treat this, but it would at least be useful to me. Like if I saw some improvement in those parameters, I would feel more comfortable about continuing the therapy.
So let me just ask one more question before we move on from our first discussion period, because we have I think three, so I don't want to linger here the whole time. But um, you know, we were talking about ruling out an infection, and I think that's, very appropriate and certainly something that would kind of give all of us pause before we just plunged into immunosuppression right out of the gate for this gentleman. I do think the question, Jocelyn, that you raised earlier about this being a CD4 positive alveolitis is important, though, right? In the sense that I have a pretty hard time distinguishing somebody who comes in with kind of an acute sarcoid presentation from somebody coming in with iris. And this is something that I haven't seen discussed all that much in the literature, but in theory, both of these are CD4 positive alveolitis, and both of them are characterized by a response to some antigen that the lung didn't really cooperate with. And I think that gets to your point about how you would expect the CD4 count to be a little bit higher in somebody who's clearly got enough cells circulating to mount a response. The the data I've seen for sarcoidosis and granuloma formation, I think it's somewhere in the neighborhood of 60 to 70% of them have P. acne present in the granulomas on 16S sequencing. I haven't seen any comparable data like that for this patient population. Is that something either of you ever encountered, or any thoughts on the relationship between those two diseases? I'm seeing both heads shake no. Fair enough. Go ahead,
No, but
Justin.
can I just ask, Jonah, I don't know, you seem like maybe you were not taking care of this person in 2011, but do you know if they considered doing a bronchoscopy with lavage before initiating immunosuppressive therapy?
Yeah, so I did take care of this patient about 10 years later. But I know that when he arrived in clinic, he was on 20 milligrams of prednisone a day. And in the next slide, we'll kind of discuss what happened next and bronchoscopy.
And while we're getting there, I think we do have one question in the chat about the ground glass changes. And I think that more of a comment to say that it probably makes sense to be more aggressive given how damaged that CT was. So why don't we let you take it from there and we can see how things evolve, Jonah?
Perfect. And thank you guys so much for the discussion. So yeah, he came in on 50 milligrams a day, and that had been kind of left on from when he was in North Carolina and was originally diagnosed. So he is tapered to 10 milligrams and doesn't really get any worse from a symptomatic standpoint until the end of that year. At the end of that year, he experiences a kind of subacute decline in functional status, increasing cough, increasing dyspnea, and the differential includes PJP because of his persistently non-reconstituted CD4 count. And in part for that reason, he's scheduled for bronchoscopy and biopsy. Bronchoscopy and biopsy are performed, and the granulomas are noted to be extremely well formed, extremely well organized, with very little surrounding interstitial inflammation. And so it's thought to confirm the diagnosis of sarcoid, and none of the other infectious disease testing was positive, including negative studies for PJP. And so for that reason, his steroids are up titrated again. And they kind of are remained elevated for the subsequent years that he's in care. Um, Unfortunately, around 2014, he falls out of care and he isn't seen for a couple of years. So as far as we know at that point, he's still receiving chronic steroids. But he actually represents to clinic in 2018, and he acknowledges that he hasn't been on steroids since falling out of care. And so essentially has been untreated for a couple of years. And he comes back to see you and has this CT now. So the CT is interpreted as remarkable for now fibrosis, traction bronchiectasis, architectural distortion, all of which have been absent before. His heart also looks larger to me. On PFT, you now see actually severe obstruction, with a bronchodilator response, a reduced total lung capacity, and a further reduced TLCO. And so he started on budesonide formoterol and continued on prednisone. There's also been some changes in his antiretroviral regimen, and he is being treated for the hepatitis B. He's found to have both airways obstruction and wheeze, as we saw in that previous PFT. But he also has multiple bronchiectasis exacerbations, green purulent sputum, and Pseudomonas is cultured on numerous occasions. And so his bronchiectasis is treated with inhaled tobramycin. There's a discussion of biologics for sarcoid, but as we discussed, he still has insufficient control of his hepatitis B, and he has chronic hepatic inflammation, which is thought to be limiting factors, in addition to the frequent infectious complications that he's experiencing.
That's an unfortunate evolution, but I think I I can remember a number of patients where I've had this happen, where I sort of had ground glass and then folks fell out of care and came back with fibrosis. It's never an outcome you like to see. Um, I think in just if I can point out real quick, Jonah, if I'm not mistaken, the ground glass that you showed us, just to go back to the question that was in the chat from 2012, it did look like, I mean, we don't have sort of follow-up PFTs from that time, but this does look better than what you showed us initially, if I'm not mistaken. Can you show us that original?
Yes.
Yeah. I
Yeah.
mean, it does look like we had some improvement there with this, because I think to the points we were discussing earlier, it's really important to have some sort of objective criterion we're following, in addition to sort of hearing them out on symptoms, or we're going to have somebody on therapy indefinitely, and this is not somebody we want to try that in. But to go back to sort of where we are at this point in the case, so we have significant fibrosis now, and this is, I think, also a unique challenge in folks with HIV. I wonder, sort of, if we remove this from sarcoid in particular, do either of you have any experience using antifibrotics in people with HIV? Do you have sort of thresholds or cutoffs that you like to use for that?
I cannot say that I have ever treated an HIV patient with an antifibrotic. Um,
Neelima?
Yeah, not that I can think of. No, and I'm trying to think of, patients that I might have like peripherally seen on the consult service or something like that that have, but none that come to mind.
Understanding that they weren't in such heavy use at the time that when this patient sort of came back, and sort of they've been steadily increasing in use since some of the earlier trials were published. Is this somebody, if you saw him today, you would consider these therapies for?
I mean, I don't know what else there really will be to offer if he's not a candidate. So I'm still not 100% sure how much of his symptom worsening is driven by fibrosis versus inflammation, and whether there's residual inflammation there. If he's been on 50 of prednisone, that's usually a pretty good dose. So my inclination would be to suspect that it was progression of the fibrosis that was driving some of his symptoms, or another comorbidity that hasn't been detected, a complication of sarcoid, something along those lines. But I think if I did that whole evaluation and I was convinced it was really just the fibrosis, I would consider it. I think that sarcoid patients were excluded from the pirfenidone trials
Mhm.
for progressive fibrosis, but not for the nintedanib. But certainly that's like a tiny subset of patients. I also, again, I would have to consult a real HIV expert here, but I would suspect that nintedanib maybe has fewer interactions with other medications than pirfenidone, but I'm not 100% sure about that. So I think I would, have a conversation with the patient about the sort of risk and lack of real convincing evidence, but probably approach it kind of using shared decision making about whether to do a trial. nintedanib, perhaps.
Jonah, can you I agree, I think, with everything that Jocelyn says. I think it's hard to sort of know and agree that I'd be concerned about sort of like drug-drug interactions with his ARTs, especially it's like if I remember correctly, these are all like cytochrome P450 metabolizations. And so, how does if he's on protease inhibitors and an RTIs, how that sort of could affect clearance of those and interactions with those. Jonah, can you go back to his PFTs? Sort of what was the PFT change that we saw?
Yeah, so he had had a moderate restrictive defect on his initial PFTs, but by the time he comes back into care, he has severe obstruction.
Yeah. And it's sort of, yeah, it's interesting that he sort of developed severe obstruction. So how much of this is being driven by sort of like airway process, like his symptoms are being driven by like more of an airway centric process versus a parenchymal process. And his lung volumes
Reduced.
were reduced, but hadn't changed significantly over this time, or
He
I
had
don't remember
he
what
had a
was.
significantly reduced TLC relative to his initial presentation, but his
Okay,
FEV1 had increased even more dramatic, or sorry, decreased even more dramatically.
got it. And his DLCO
It
had
had
worsened
been
as well. Yeah.
exactly. It had been low, but it was lower.
Yeah, I mean, I think this is just, it's a perfect case for discussion because it's very complicated and there's all these sort of different factors, right? So how much of this is being driven by how much of his symptoms are really just being driven by obstruction um and potentially now like some new pulmonary hypertension and bronchiectasis and recurrent exacerbations from that versus how much of it is really driven by the fibrotic process, which, I think someone else can correct me if I'm wrong, sort of, the fibrotic process in sarcoid is now sort of being thought as like a separate sort of not necessarily the same thing as like like the acute immune reactions of like acute sarcoid and inflammation, but sort of a distinct entity. And so I think my approach in theory would be to try to, think about sort of how much can I intervene on his obstruction and his bronchiectasis and his airway clearance and sort of reduce those exacerbations, sort of see how he's doing, recognizing that in the background, it probably assuming that in consultation with his infectious disease doctors or his HIV provider that, we don't think there's going to be severe drug interactions with his ARTs starting in tentative and sort of seeing how he does. I worry about the side effects and, I always sort of think about like how much sort of like clinically important impact you're going to get from that stable FVC, stable lung volumes from your antifibrotics. And in someone like this, where there seems like there's a ton of different things contributing to his symptoms, sort of weighing that and against sort of the side effect profile and some of the other things that might be happening.
Yeah, I think that kind of multifactorial approach is exactly what the clinic pursued at that time. I should mention that he's still smoking, right? And that was sort of an active problem from the time that he first showed up. And they've tried gum, they've tried patches, he tried Chantix, but he had negative CNS effects, sort of the psychiatric symptoms. Interestingly, he had similar psychiatric symptoms precipitated by some of his antiretroviral medications, and they had to be adjusted. And so, he does endorse that in periods where he is able to achieve smoking cessation, his symptoms are much improved. And so as you guys have alluded to, kind of addressing those foundational aspects of pulmonary medicine in this patient who has really many of the different conditions that we tend to lump together here.
It is a pretty exaggerated airflow limiting response here and a pretty exaggerated bronchodilator response that you're seeing. I guess I have not personally had a ton of luck putting these people on inhalers in the past. I mean, most of them don't want to let go of their albuterol, but I haven't, putting them on inhaled steroids, I just haven't seen that much of a bump in the past. But again, as I think both of our discussants have alluded to, these folks don't come in every day, so I don't think any of us are drawing from a ton of clinical experience here. Um,
Yeah,
now,
I will say, Bashar, just to that point, that I do feel like the folks that have sort of on bronchoscopy, when you sort of see like the sarcoid papules, like throughout the airway. Those patients, I do feel like very anecdotally in the VA, concomitant high like tobacco use population seem to, again, very anecdotally, really like their inhaled corticosteroid and feel like that really helps with some of their symptoms. And so I think sort of depending on, I don't know how much you know about the bronch and what that looked like, but that I do wonder how much of this is like more classic COPD from tobacco use, airway obstruction, plus or minus the sarcoid, plus or minus the increased risk of obstruction that we know that, patients with HIV have, sort of independent of everything else. And so, if that's something that could be more easily and I think targetable and more quickly sort of informative of symptom burden than an antifibrotic.
The reason I ask about the antifibrotics is that wouldn't have even been on the table here. Our
Yeah.
ILD group, unless they have a very clear UIP pattern, it's just not even considered. And I think that's, not a uniform practice across the country, but that's certainly what I've run into here in Atlanta. For better or worse, I don't use those medicines a lot. I don't have any idea, how I should expect people to respond to those. My sneaking suspicion is that the mechanism, that kind of drives the fibrosis is probably not the same in folks with HIV as it is in the patients they're otherwise seeing, and might be a little bit more comparable to a CTD patient with a dysregulated immune system. I mean, certainly we see a lot of LIP crossover between those groups as well. But no, don't get me wrong, Neelima. That doesn't stop me from putting all of these patients with these airflow findings on the inhalers. They just usually tell me they don't do much. But yeah, that doesn't stop me. So I think the the other, I guess, question I wanted to pose to the group here before we move on is just the broader question of fibrosis in HIV in general. So we have somebody who seems like they've got sarcoidosis. I think, that's continuing to be the working theory based on what the clinical team has come up with, and I think that's understandable based on the wrong findings, et cetera. Um, but we have, a fair amount of data, not a ton, but a fair amount of data suggesting that people with HIV tend to fibrose more often. And so I think the other question, and Jonah, this may be something that you're privy to, but maybe not, that period where he was absent from care, I just wonder how much, like, did he have pneumonia a few times? Did he have like some, what seemed like bad upper respiratory infections and never came in? Because I would say about maybe three-quarters of my ILD referrals in my clinic end up being, this person had a bad pneumonia and nobody really followed up with imaging afterwards, and they were probably just fibrosing down, and there's really very little to do but work with the lung function we've got at this point. Is that information you have in this guy?
Yeah, so I don't know what the state of care everywhere was in 2012, but the way it's documented, he was presenting to other institutions.
Mm-hmm.
And he was even in and out of outpatient care at some of those institutions. He certainly in this period has frequent admissions for what's called pneumonia, even within our own institution, where it's very difficult to distinguish in this patient with abnormal baseline imaging when it's an infectious exacerbation or an acute pneumonia or just progression of his sarcoid.
That makes sense.
And
Um,
Jonah's stable on his ARTs or sort of like periods of like coming
yeah,
off of ARTs and viral load sort of, going back up, etc.
He has very consistent follow-up with the clinic here. And there are some modifications made over time with an eye towards his hepatitis B and some of the side effect profiles. But really, he's in care with some missed doses and generally undetectable viral loads and generally low CD4 counts.
I just want to put in a plug. I see in the Q&A we have a plug for a focus on bronchiectasis management. I will say this seems to be the thing that Snookers, our ID colleagues, more than anything else, is just sort of treating that as sort of something that happens with HIV primarily, and just sort of the route to take when it occurs. And so I find that when folks come to me and they've been in the hospital 4 or 5 times, in the last few months, there hasn't been a lot of attention to airway clearance. There hasn't been a lot of attention to sort of I think, standard of care bronchiectasis management. But I think it is worth highlighting that that seems to be where the money is right now.
Yeah, and that's really the direction that the clinic went at that time. It was
Mhm.
heavily on, counseling on lung clearance, working with the ID colleagues to get that implemented, and then treating with the inhaled tobramycin.
Excellent. Well, why don't we let you keep going with the case and we'll finish it up here, Jonah.
Absolutely. So unfortunately, the patient then presents to the ER with hemoptysis and dyspnea. He's found to have a room air saturation of 64%. He's diaphoretic and he reports chest tightness. His vitals reveal tachycardia, tachypnea, and relative hypotension. And his CT scan is unfortunately remarkable for a right lower lobe segmental pulmonary embolism. He has an echocardiogram performed, which is remarkable for a very dilated right ventricle with very little function. He had had echocardiograms performed at prior points in his care, and there was some pre-existing right heart dysfunction, but this was dramatically worse. And fortunately, he recovered. He was discharged, and his right heart cath and follow-up showed persistent recapillary pulmonary hypertension. And he was started on riociguat, which demonstrated an improvement in RV size and function. And of course, that was with the understanding that this was CTEPH. But his sarcoid continued to progress. Now it was involving his liver, his skin. He had an episode of uveitis. He finally quit smoking. And he was seen frequently in the pulmonary hypertension clinic, where it was thought that his VQ scan was low concern for CTEPH and that his RV dysfunction was out of proportion to his clot burden, that probably there was a component of group 3 pulmonary hypertension at least, and probably also a component of group 5 pulmonary hypertension, and potentially also a component attributable to his HIV status.
I had a professor in medical school who used to talk about how when he was training, if you really wanted to learn medicine well, you learned about lupus. And he said when, as he kind of matured in his training, he said, that's probably still true to an extent, but if you really want to learn medicine, you should learn HIV because it kind of does a little bit of everything. Now I'm convinced, Jonah, you don't even need to learn HIV. You can just go through this one case and kind of hit every possible thing that can go wrong with your pulmonary system. So let's just start with, Neelima, why don't I start with you this time? What's your sense of VTE in HIV? Is this something that, let me, I guess, present the clinical scenario this way. Somebody comes in with a clot. Do you think of HIV as a permanent risk factor for further clots and kind of push for indefinite anticoagulation? Or do you think of this as it needs to be HIV plus something else to really push them into a thrombotic state?
Yeah, I guess my sort of like personal opinion informed a little bit by data and a little bit by just experiences that, especially in patients that have, he's in this sort of in between, but especially in patients that have uncontrolled HIV, low CD4 counts, or high viremia, or at least detectable viremia, I think of those as sort of as like here's general population risk, and this is like an increase, they're sort of at an increased risk. I think the question about sort of whether to keep them on indefinite anticoagulation really depends on a few different things. But I think if we're sort of really calling it unprovoked, so like it sounds like he didn't have a recent surgery, didn't have a prolonged road trip or airplane ride, et cetera, et cetera. I think the data now, sort of my practice has moved towards trying to keep people with unprovoked VTEs on long-term, potentially lifelong anticoagulation without another reason not to long term as sort of standard practice. And so I think especially, if you add on the sort of like question of HIV, a relatively low CD4 count, sounds like, fortunately undetectable viral loads, but still sort of this up and down. I would think of this as someone who I definitely would want to keep on long-term anticoagulation for as long as possible. The hemoptysis and the bronchiectasis makes me a little bit nervous. I think that part is, sort of that question, it sounds like it's a subsegmental PE, and how much is that really driving how much of that was really driving his hemoptysis. And I don't know if this was, large volume or just like small blood streaks, but and not seeing like all of his imaging, sort of knowing how bad his bronchiectasis is getting, how much of that would, sort of limit long-term anticoagulation is a question at the back of my mind, and I think sort of changes the risk benefit, balance a little bit. But I think, assuming his hemoptysis wasn't super significant and we're not worried about sort of like a bronchial artery bleed otherwise, would favor trying to keep him on long-term anticoagulation.
Yeah, and he did have both before and after this presentation, other presentations with hemoptysis, but fortunately always small volume.
Yeah, I mean, I do think that gives everyone a bit of pause. Hemoptysis is never a fun presentation, sort of like consult question coming through on the pager of someone with like bronchiectasis on, or sorry, hemoptysis on anticoagulation. And so I think, that might limit your ability for long-term anticoagulation. But I think, Bashar, getting to your sort of question, I do think of HIV as sort of a risk factor that puts people back above sort of general population risk. Unless they have like really well-controlled HIV, undetectable viral loads, normal CD4 counts, sort of more in like the 400 to 500 range, then I might sort of think about sort of, like their risk stratification might be a little bit different, but unprovoked PE anyway.
Yeah, I would agree, and I would just add that I think patients with sarcoidosis in the absence of HIV are also at increased risk of thromboembolic disease, and so as if he needed another reason, I think I would favor the same approach. And then I guess the third factor would be the RV dysfunction and his ability to tolerate or survive another thrombotic event. And so I would use the same approach.
So let's pick up on that RV dysfunction for a second. So, it's he has several different potential causes of his pH, and it's a little difficult to kind of suss out which one's driving it. You know, Hearing Jonah's presentation, I was kind of surprised that the patient was started on riociguat, not in a questioning way, but just I don't think our group here would have done that. I think they're a lot more kind of they need to see one kind of pure, like this is CTEPH, and have the VQ go along and kind of have everything matching. It does seem like it helped in this case, and so I'm kind of struggling to think about how I would have handled it in their shoes at that time, if that's something I would have really pushed them for. Neelima, do you have a vote there?
Yeah, I mean, I think my sort of eyes kind of went up at this like same time that yours did of like, oh, that wouldn't have been my first guess. I mean, I think if you go through like the group, it's like he's got risk factors for group 1, group 3, the P group 4, obviously, and group 5. So it's like, next you're going to tell me that he does have like left heart disease and like a bad EF, and then that's going to be the other thing. And so, I think the question just becomes like, what are your treatment, right? So in this patient that has all these different risk factors, clearly has a poorly functioning right heart, what are sort of your options on the table? And I think more now than presumably even in 2020. And I don't know, sort of like what the state of COVID was when this was all happening, but I don't know that it would have been the first thing that I reached for, but I also, I think it's also hard to know. And, the timing of the VQ scan and sort of that data and availability to like the timing of the initiation of treatment and maybe just trying to get him, out the door with something. It is interesting that he had so much improvement and how much of that was just like treatment of, his PE and, potentially other things contributing. I think it's a little fuzzy, and then sort of thinking about, how much has his, I guess the other sort of piece of data that'd be helpful is like how much has his um, pulmonary function worsened, how much of this is sort of really being driven by sort of more of a group 3 process or the sarcoid, and what that looks like, I think would be the other thing. So, assuming that there was some stability there and you have a new PE, I guess I would say that I agree. I feel like our group probably would also not have started him on that, especially if he had a VQ scan that was negative. But I think, a rock and a hard place. Sometimes you got to throw the kitchen sink.
Jocelyn?
Yeah, I was actually curious about the same thing, and I was curious about the idea that he had CTEPH, and so I was just sort of wondering what the timing was between the presentation with the PE and the right heart catheterization, if it was a period of a few months or kind of where that fell.
Yeah, it was a period of a few months, and as Neelima mentioned, we're this is September 2020 in New York City, and so we really don't have pulmonary function testing for a number of months. Everything is telemedicine, and care is even more fragmented than before.
Yeah, so I'm assuming that's where the reassessment came in, right? Is that the assumption was that this could be CTEPH, and that was the indication.
Right.
All right. Well, I think Jonah, why don't you wrap up the case for us, and then we'll kind of get final thoughts and see if anybody in the audience has any other questions we should cover before we close.
Sounds good. So continues to have frequent admissions for dyspnea. He's finally able to start a biologic, and that was an enormous effort coordinated through rheumatology, pulmonology, and ID, kind of when trying to get everybody comfortable with the degree of infectious complications, and the degree of hepatic inflammation. And eventually he's able to start infliximab, then prior auth, and eventually he does actually get the medication. He also starts treprostinil with the heart failure pulmonary hypertension clinic in addition to the riociguat. Unfortunately, he developed spinal compression fractures. And he is still on low dose prednisone at this point, about 10 milligrams a day, in addition to the biologic that he started. And so he's admitted for a kyphoplasty. And his course is complicated by postoperative pneumonias. And unfortunately, this is when I met the patient, and we cared for him inpatient for a very long time. And he ended up going into multiple pressure shock and a pulmonary hypertension crisis, experienced profound respiratory failure, and unfortunately passed away in our ICU. So, I think this is somebody who we had a very long-term relationship with. And so I want to thank everyone again for giving us the opportunity to sort of honor his memory through this presentation. And it's really been a privilege to hear your perspectives on the care.
Well, Jonah, first of all, thanks for going through that, and also these are really tough cases, and it's tough. I think, I recognize that you came in on the tail end, but just sort of hearing the historical perspective is very helpful to sort of see how these things evolve, and also think about how they might evolve if this patient came in for the first time today. I think we might have, we have more data than we did. We don't have as much as we want, but we might have been, more aggressive in starting some of these therapies earlier. We might have been able to get them off the steroids sooner as sarcoid care has evolved, that sort of thing. But no, thank you for going through all that. Let me just ask our discussants, do you have any final thoughts you'd like to share before I open it up to the audience? Jocelyn, why don't I start with you this time?
Sure. Jonah, I'm sorry if I missed it. Was he intubated for the kyphoplasty? Did he
Yeah,
have general anesthesia?
he did. Yeah.
I mean, it's tough, right? Because obviously you have to treat the pain from those compression fractures. But intubation in a patient with bronchiectasis and a history of recurrent infection and right heart failure and pulmonary hypertension is obviously always a high risk endeavor. I was just curious whether there had been discussion or consideration for whether the procedure could be accomplished with moderate sedation or other approaches. But yeah, an unfortunate outcome. Obviously, he received extraordinary care to have survived for that long with that many really serious complications and comorbidities, and sounds like a challenging case to manage.
Yeah, and he was successfully extubated. So he was, receiving hospital level care throughout the period after the kyphoplasty, but he was extubated and then had multiple infectious complications.
Yeah, thanks so much, Jonah, for presenting this case. I think it's a really fascinating combination of sort of really complicated decisions, right? And hindsight is always 2020, and I think we're talking about like a 15-year evolution and sort of our knowledge, as Bashar sort of points out, about how to best manage sarcoid and sort of what even therapies are available for patients, and including for pH. And so, really hard to sort of know all of the different factors. It is interesting how much, despite everything else, that it's sort of infection that gets, like that sort of was a driving factor, like recurrent pneumonias. And I think just goes back to highlighting how huge of a role that plays, and sort of the pulmonary toilet and all of that, in terms of managing, you know, any patient with immune suppression and bronchiectasis, and everything else that's going on, is that one infection really can really change the course for somebody. And so, despite being able to overcome a PE, and his having severe pH, and sort of doing all these other things, that it is those infections that really ultimately land him in the ICU. And the fact that he had a PARS from a mucus plug, I think, is just highlights sort of like, it's as complicated as patient accepts. Like, it's the basic things that really sort of tend to be really difficult for us to sort of like manage and get past. So yeah, I think really interesting, and lots of thought-provoking sort of questions and discussion. So really happy that you were able to share this with us.
Yeah, this is, I mean, a great case of just not having any reserve left when you have this much going on, for sure. But it is remarkable that he was with that much going on. It was remarkable that you guys were able to kind of keep him going as long as he was, especially with those gaps in care and everything else going on. And you didn't mention if he ended up quitting smoking by the time he made it back through the hospital. I don't know that our orthopedists will do the kyphoplasty if they're still smoking. That's I don't know. That's a different problem. But good. Let me just open this up just for our last few minutes. Any questions from the group that were not covered during our discussion? Anybody have any comments they'd like to share with the group? Well, I'm not seeing anything show up in the chat or the Q&A. So I think in that case, why don't we just take that 4 minutes back, and I will just thank Jonah for presenting a very complicated, very interesting case, and Josalyn and Neelima, thanks so much for your expert discussing, and we will hope to see you all back at our next HIV Pine session. Take care, and thanks very much.